Thanks you guys for coming out today for what I think is a really important conversation. I also want to thank Dr. Murphy for joining us today to talk about Governor Cooper's response to the spread of COVID-19 in North Carolina. We here at NCGOP feel that this is a very important conversation because of the governor's failure to provide any transparency or certainty to the families and small businesses of North Carolina who've been affected by his lockdown of the North Carolina economy. In terms of his administration's lockdown, we are troubled by the fact that the governor refuses to hear the concerns of small businesses, work with his own council of state or the General Assembly, or even hold press conferences which are open to the press. We also remain concerned that Governor Cooper has adopted a clear double standard when allowing protests with thousands of people who are not practicing social distancing or other health protocols to take place, and shutting down events like the races at the Ace Speedway in Alamance County and the RNC convention in Charlotte. We appreciate Dr. Murphy's leadership in Congress on the issues arising from the spread of the coronavirus, where he's been a voice of reason and expertise who is listened to and respected by both Congress leaders and President Trump. So Dr. Murphy, thank you so much for coming in today.
Thank you. Good afternoon, everyone. I hope everyone is safe and doing well. Let me just pull a little bit of stuff over here. I don't want to break it. Some may wonder why, as a federal official, I'm showing up here. Speaker Pelosi has kind of banned us from Washington, D.C. This healthcare issue, the COVID-19 pandemic, has been on my radar since the beginning of January, and I care about the health and welfare of the people of the state, and have been studying this relentlessly. And so I'd like to present today a little bit of my thoughts of where we've been, where we are today, and possibly where we can go. I'm going to give you a little bit different thoughts than some, just because I'm a different physician than one that has been mostly speaking to you guys. We're obviously facing a pandemic and something that's changing our world, our nation, and our state, unlike anything we've ever had before. Emotions are running high, understandably so. They range from anything from people being minimally concerned to complacent, to acknowledging that there's a problem going on, to a full-blown panic and fear. I hear constant frustrations from people because the implementations of policies have been charged and seen as goalposts that are being moved constantly, and possible political motivations behind some of the processes. You know, as I've said many times before, in this state, in this nation, on the county level, everywhere, we've literally been building a plane while we're flying it. So I don't know, I'm not here to point out wrong to anything that's been done in the past. I am going to point out opportunities I think that were missed that would have put us in a better place today. You know, we made a lot of assumptions, some of which were correct, some of which were incorrect, and the fact that we've learned so much just in the last several months about this gives us some measure to move forward. As I've said maybe before and several times, like when I was in the General Assembly in Raleigh, I still practice medicine. I think it's an important thing to do for me to maintain relevancy with the medical providers. I'm empathetic with them. I was just in our institution last week. The heroic doctors and nurses, other healthcare personnel are still fighting this battle on the front line. They're working long hours. They are dedicated individuals, and they deserve our highest appreciation. What we face now is a very difficult task, and that's a balancing act. A balancing act between safeguarding the people, their health in this state, while at the same time letting people get their lives back, get back to work, get back to school, get back to church, to seek life's fulfillment. And so I've heard this many times before, that we cannot be so afraid to get sick that we forget how to live. So there are certain things about this pandemic that we must accept, that we cannot change these. And if we check our politics at the front door, work together, then I think we will achieve a much greater outcome. You know, as I said, my purpose here is not to criticize actions. I do want to highlight some of the points in the science and the data that perhaps have not been brought out to light. And I think it points out the opportunities that we have missed. You know, I see this entire crisis as a scientist. I do that because I'm a physician. Since January, I have spoken with multiple infectious disease experts, Dr. Fauci's team, Dr. Burke's team, the Surgeon General's team, multiple other infectious disease departments across the nation. And I think what we do is we treat this entire episode, at least I have, like a sick patient. we gather truths. And it's fully transparent, and it's with full transparency and truthfulness that we best treat our patients. I think this is definitely an area of opportunity that has been missed in our state, and I think it's one that if we embrace moving forward at all levels, transparency and truthfulness, that we will have a much better outcome. When I was young, my mother told me that telling half the truth was really a lie. So we want the whole truth. We want everything out on the table so that people can understand the entire situation. I think we've lost our way a little bit. I think we've wandered from treating this as an entire issue dealing with medical science and dealing it a little bit more with political science. And what that does, it leads to mixed signals and frustration and division in our state. And it's something, especially during this time of crisis, that we just don't need. There have been many opportunities to seek consensus and communications that we've missed. And I think if we show some consistency in doing that moving forward, we will be in a much better place. We show consistency in treating groups the same way, businesses the same way, so that we're not picking winners and losers haphazardly. We also need to be transparent in what we do. We can't keep one group differently than another group just because they're of a particular political affiliation or protest move. And finally, communication. Communication, as with so many other human interactions, is key to people regardless of which political affiliation that you have. Communication is key to be on the same page, and so that people have their opportunity to voice concerns, to offer input, and actually put a unified North Carolina message moving forward in a much better place. We've been on now, if you look at the curves, we've been on a continuous and steady rise in North Carolina, and I'll show that slide in just a second, for over the last 6 to 8 weeks. And I'm going to reiterate a conversation that I had with Dr. Burks when she recalled a conversation with Dr. Cohen. And that she was alarmed at our persistent and steady increase, but she said emphatically that this had nothing to do with the state reopening. There's no spike that happened after the state reopening. This has been a persistent and constant increase, and pointed out that there has been probably a fundamental flaw that has led to this constant increase in what the approach has been so far. We talked about flattening the curve, and I just want to reiterate this. In my first part of social media, we all talked about flattening the curve, and that's what was everybody's on their mind 3 months ago. But what you would notice here, if you remember your 9th grade geometry, is we flattened the curve such that we would not overwhelm hospital resources. So flatten the curve to get hospitals time to gather those resources, get physicians prepared, get ventilators made, masks sent out, PPE required, and that's been done. So we pushed the curve down. And again, this is where some people have been very frustrated about the goalposts. The area under the curve, at this point in time, without herd immunity, without a vaccine, has not changed. And both of those things are months, if not years away. So I think it's important that we don't move the goalposts, that we give people a constant expectation of where we are and where we need to be. So thank you for moving that. We've done all the right things, and I supported 100% the closing of the state at the time. In fact, I urged it because I thought at the time a haphazard county closing wasn't doing any good. And I believe the state did the right thing in closing all businesses down because we did not know what this virus was about. We didn't know about its R naught, its infectivity ratio, but obviously as time has occurred, those things have changed. So let's look at the data. Let's look at what North Carolina shows. This is just a couple days behind just because I was on a plane and had to send it. I think the important key point is, death is a very difficult thing, endpoint that we deal with in medicine. I've been in medicine for over 30 years. And unfortunately, it's one of the things of life we have to deal with death. We have to deal with it in medicine. But it's very important that we look at populations. Who is most at risk to actually have a bad outcome from this? Not just get sick from it, because we get sick from colds and other things, but who's most at risk? And this obviously is the age group. It is our elderly age group. Okay? 65 to 74-year-old, they have about 20% of the deaths. And we see that 2/3 of the deaths in North Carolina have occurred in 75 and older individuals. 2/3. Now again, this is information that we should have had readily available at the beginning. It should not have required a lawsuit for us to get. This is something that should have been transparent for us to know about. So, guys, the virus, just like any other virus, has an endpoint that we don't like. It shows that people do succumb to the disease, just like HIV, just like H1N1, and the other viruses that we've talked about. is that one other slide in here? Yeah, let me just flip these right here. All right, we're good. So let's talk a little bit about, again, where the deaths have occurred and on whom they have occurred. We have seen, and the statistics changed a little bit over the last 48 hours, we had a disproportionate number of individuals who were African American who died. We also, again, had obviously the higher folks of Caucasian North Carolinians died. That's changed a little bit. I will tell you that we really need to do a much deeper dive, because I don't think the pigment in somebody's skin is a problem with this virus itself. It looks to underlying disease states. African Americans have a higher rate of obesity, hypertension, kidney failure, those things which have turned out to be the highest risk factors. And so while it looked like it may be affecting African Americans just by skin color, that's not really the case. It's because of underlying and most likely predisposing disease. So, and I think really the most statistic that really bears the biggest problem here, and again, this took a lawsuit. It took a lawsuit for us to figure out this data, and that's wrong. That's not being transparent. And so we're finding out that literally since we've gotten this information, the quotient has been very, very stable over the last 6 to 8 weeks, that approximately 2/3 of the deaths, not quite, it fluctuates between about a 60 and a 63%, have occurred in resident care facilities. These are state licensed nursing homes, and these are obviously the hot spots of what has happened where people have succumbed to this disease. Now, we just have to look at this. We have to understand what's different about those populations. They're sick. Those folks are sick. They would not be in nursing homes if they were not. In fact, if you look up, just take a quick Google search. If you look at folks who put in nursing homes, their median survival, half of them do not live more than 6 months. So we look at a population that is very, very frail. But unfortunately, that's where our deaths have occurred. And this is going to be in a stark contrast to what another state has done, Florida, for example, and the way they jumped on their nursing homes very quickly. I think we are a little bit behind the 8 ball. It's an opportunity, again, for us as we're moving forward and as we're learning now that there are more and more cases, that we can really improve upon things. So you can move that one. That was really a key point that Dr. Burks pointed out, is that we need a plan, a true plan for our nursing homes. We need to be able to, and we look at nursing homes, we look at prisons, we look at agricultural entities where we need to have a plan for testing, we need to have a plan for egress and ingress of individuals, and heretofore we've really not had that. We need that plan moving forward. And so fortunately, even though we've had numbers of cases that have continued to rise, fortunately, the bad outcome with COVID has continued to fall. And I believe that even today has fallen down even a little further. That's a good sign. It doesn't mean that people are not getting infected. It doesn't mean that people are not getting sick. It means that people, fortunately, are fewer are actually succumbing to the disease. And so that's a definite good sign for the state of North Carolina. So let's talk next about another key point. And this is one that there are really two statistics that are most important through all of this. And those are who gets sick. What's the sick ratio? Okay? And we know that with our deaths, because those have been going down. But this is the curve that bothered Dr. Burks the most. Is that we've seen, if we could just, we got it there. We good?
Very good. I think we're switched.
I think we're good. If you can see, and I wish I could blow this up a little bit better, is that there's been a gentle rise, and if you could bring this out for 2 months, you would see this all going up as a gentle curve. Now, it's a little bit of a sawtooth pattern. Some of that has to do with reporting. States don't report on the weekend. State labs don't report on the weekend. You get a big jump in on Mondays and Tuesdays with information. So there is a sawtooth pattern. But what you see is obviously a continuing rise in the number of hospitalizations. And I think when I checked this morning, it depends on how accurate that data is. I believe that number is 770. The ICU data, the number in the ICU on the state website, I'm not sure is correct, because I called around to a bunch of ICUs, medical centers in the state today, and I did not get such a number that the state did. So obviously what we've seen is an uptick in hospitalizations. Again, flattening the curve. Flattening the curve did not mean that the virus was going to go away. It did not mean that if we hide under, in our houses for 2 months, that when we come out, that it's magically going to be gone. It's, again, the purpose of flattening the curve was so that we could get hospital resources to take care of those individuals who were infected while we wait for better therapeutics, while we wait for vaccine and possible herd immunity as people get infected. So now let's bring up the next one. And I think this is really what's going to be key for the state of North Carolina. Okay, this is just a comparison of North Carolina as far as the number of beds available. This is from the IHME, the University of Washington website. So basically, we've done very well in North Carolina, staying under that area where we have beds available. We have plenty of ventilators. Nobody in this country has been denied a ventilator. Nobody in New York, nowhere. So, I mean, we have plenty of ventilators. We find actually with this particular pneumonia from COVID compared to like the regular flu pneumonia, you actually stay on a ventilator longer. But there's not been anybody in this country who's been denied that. So, all right. So let's talk a little bit now about testing. There was a great call several months ago that we needed to ramp up a lot of the things. We needed to ramp up PPE. We needed to ramp up testing. We needed to ramp up ventilators. And thankfully, American industry has come to the rescue. They've really helped us. Some of the CDC first came out with tests, which were horrible. They were wrong, and that really put us behind the 8 ball for about 3 or 4 weeks. But we now have very, very good tests, and their availability is, it's not perfect, but it is much, much better than it was even 3 or 4 weeks ago. So we talked about testing. If you'll look at some of these lines here, this is what's happened in North Carolina. We continue to skyrocket in the number of testings that are going on. Now, one thing that was said a couple weeks ago, which I felt was just, again, a half-truth, was just talking about the number of cases being the record that we achieved. Well, that was true. That was definitely true. But the other half of the equation that completes a truthful statement is the fact when you have testing, when you look for something more in medicine, you're going to find it. And that's what we found here. We found things more. People were clamoring for testing, but then people didn't understand what the results would mean. When you test for something more, you're going to find it more. That is the true data. That is the true science. We have labs all over the place. The hospitals are using their own labs, which I'm going to speak to in a minute, which I think is really a missed opportunity why we're not using hospital labs more than the state lab and things like LabCorp and Quest, because they can turn them around a lot quicker and they know things a lot better about their community. So let's look more about what we're going to do as we move forward. As far as testing goes, again, we've done what they call, you can leave that up there. We've implemented one type of testing in the state, and that's called contact testing and tracing, which just as an explanation, you find out that somebody has had it, and then you go and find out all the other people that they were exposed to. And that just chases that person down. And that's great. That's one part of testing. But what we're failing to do, and which we should be doing now, especially in this particular light, is we should be doing surveillance testing. Surveillance testing is going out into at-risk communities and going into a nursing home, going out into an agricultural plant, and testing individuals to see, is that going to be a hot spot? Because then it's just like running out to a fire before it gets bad. You go and you attack that, and you swarm it. You swarm it, you take it over, you go in with a testing team, and you go and you knock out that fire. We're not doing that here. We're not doing a surveillance testing. And so that's definitely an opportunity, again, as we see things moving forward, that this state needs to do. Again, it's another side of the equation. The other part of that's surveillance testing, and the other part of that is antibody testing. I think everybody remembers about 6 weeks ago after the big surge in New York is they did testing. They did antibody testing in New York. 20% of the individuals, unbeknownst to them, had already been exposed. And why is that good? Because it ratchets down the fear factor a little bit. And that's one thing, unfortunately, with politics and some of the things that have been said, some of the things that have been done, is that people play on people's fears. Wouldn't it be nice to know the prevalence of asymptomatic infections in the community? So it's like, okay, I can actually breathe and I can actually stop the anxiety and tension. So those are 3 types of testing, one of which you're doing, 2 of which we need to do. Missed opportunities in the past, but hopefully new opportunities as we move forward. So the state now has about, and continues to have about a 9% positive rate, which has been fairly stable. We've jumped between 9 and 7 and 10, but that's about what we can expect, which is fairly comparable to the other states that surround us. And I think that's a reasonable number that we should expect as we move forward. I will say this, when we were talking about testing, and for the life of me, when I found out that the state lab, in the middle of a pandemic, the likes of which we had never seen before, was closed for the 3-day Memorial Day weekend, I really had to question that. I just didn't understand the motivation behind that. I know everybody's working hard, but that's literally the biggest holiday in the year, and it gives us 3 days of data that we don't get, and then all of a sudden, boom, we have a number of cases that go up. It's because batches were kept for the last several days. I just don't understand that. I don't understand the motivation behind that. So we really, we need a coherent testing strategy as we move forward. Our numbers are going up, so we really need to learn what we've not done in the past, opportunities missed, what we've done that has been good, and all those things. And so I think we can do this as we move forward. As I said before, this virus is not going to magically disappear. I don't know how much people know about vaccines. They're working very hard. They're probably over about 30 to 40 in clinical trials right now at different stages. But things about vaccines are, and again, I don't want to cause fear, but at the best of times, they're 70 to 80% effective. We had our flu vaccine in North Carolina 3 years ago. It was only about 10 or 15% effective. So that's not going to necessarily be the magic bullet that's going to make everything go away. It's good practices, it's good testing, it's all these other things. It is a piece to the puzzle. I think if we're very, very lucky, we will have a large-scale vaccine that will be available by the early part of next year. Sad thing is, we also have a large portion of our state and community that will not take the vaccine. So again, a piece of the pie, not entirely all of what we need to do. So as I said, March 30th, when the stay-at-home order was given, it was the right thing to do. You didn't know what this virus was going to do or how it was going to act. But I find it very perplexing and troubling, for that matter, to look across the country and you see that with the same data from different states, that we have Republican governors doing one thing and Democratic governors doing another thing. Why is that? There's only one conclusion you can come to, and that's politics. And to be honest with you, that's irritated the living hell out of me since day one on this, because I think it should be about our people, not our politics. And if we're going to move forward as a state and a nation, we've got to lay that door aside, and we've got to look at the science and the data, but not look at them through political lenses, but through medical lenses. We get back to flattening the curve, which we've done, and if we could just put ourselves on the other side of the curve, Italy's done it. A lot of other places have done it. We could be in a very, very good spot. Let's pull up Georgia. Okay, you pull it on. We're just doing it. We just do it. Guys, again, these are our tests, our cases that continue to rise. And again, these are the number of daily tests that we've done, continuing to go up. All right, so let's look at Georgia. Georgia's a good example because they opened up completely. I think it was in May. And their curve is much different. Actually, I'm sorry, their curve is pretty identical to North Carolina's curve. So you say, wow, okay, what's different? What have they done different in Georgia than what we have done in North Carolina? Well, that's a very good question. They opened things up. We didn't. They have the same curve that we did. So this tells us a couple things. One is that modeling is challenging. It's very challenging. And number two is, if we had opened up here, we might most likely be very well just like Georgia is. Now everybody except Virginia, and maybe it's South Carolina. I'm just trying to think of our bordering states. It's actually going down. They're going down a little bit. Everybody else, Tennessee, is ticking up a little bit. And that's what we're seeing nationwide. Again, giving us opportunities now to learn from things that we didn't do in the past, to how we can do things moving forward. So should we be scared today on June the 10th? It is June the 10th, right? Yeah. Okay, it was this morning. I came on a red eye over from the West Coast, so I'm almost on day. Should we be scared? Should we be in a state of panic? I think that's an injustice to the people of North Carolina to give that type of message. I think if we look at some of the dichotomies, some of the discrepancies that we've seen in some of the regulations and testings, it's a cause for just really division in our state. So now if we look at all has been done, so the whole United States and North Carolina and the medical profession for that matter has chased the shiny nickel on COVID-19. I think it's very important to understand that while we've chased the shiny nickel, we've hurt this other part of our population. And I'm going to give a few examples for that. We have caused collateral deaths because of our interventions, because of this. Let's talk about that. A good article in Chest, which is a thoracic surgery journal, documented an approximation that 80,000 cancers for the first 2 months of this epidemic were not diagnosed. So what we're going to see in about 3 to 4 months is a marked spike in the number of metastatic cancers, which are more lethal and cost much more in the United States. Again, collateral damage because we were chasing COVID. I'm not making a judgment on it, I'm just educating folks on what else is going on. You saw the same thing with people with heart attacks, people at home that had chest pain that didn't go out because 1, they were afraid to go out, 2, the emergency rooms told them not to go out, and 3, their doctor's offices were closed. So we're going to see a much greater spike in that, and I think there's some data from Chicago about a month ago that shows that 3 times as many people died at home during 1 week from cardiac-related illnesses and neurovascular-related illnesses than before. So there are some things that we need to think about so we don't just get so myopic that we're thinking just about death from COVID-19. The collapse of businesses. These are folks' life savings. There have been many documented suicides. Tennessee has some good examples of that, where the suicide rate has really gone up about 30 or 40% because of despair, because of not necessarily COVID, but reactions to COVID. And finally, mental health. Mental health, I've talked with a lot of sheriffs in our district and across the state. Talked with one in Arizona yesterday, actually. The number of cases of domestic violence are up anywhere from 30 to 70% higher. People stuck at home for different reasons, and it's caused a spike of this. It's really a difficult thing for us to do. Education has also suffered. Kids don't learn as well, looking at their teacher on Zoom, and this is going to be a challenge for us in the fall. I think there are some ways that we can do it and let kids go back to school. So should we be, now I'm summing up here, so should we be in a point of panic? No. Our cases are going up in North Carolina. Those are facts. Those are facts. What should we be doing moving forward? So our hospitals have the resources that they need. Again, we flattened the curve. It's not perfect, but Eisenhower didn't have a perfect force when he went on D-Day. Our hospitals are doing what they can to take care of people with COVID-19. We're in a much better spot with testing. We're getting the tests that we need. We need a much better and coherent plan with testing moving forward. The public has been educated. They know about safe practices. They know about wearing masks. They know about spacing, doing all those things. Now, this is obviously a challenge in our society. You know, we're in a free society. We cannot mandate that everybody wear a mask. There are some states that have put a law on that, but it's very difficult to do in a democracy. So people have their freedoms and they want to keep it. I think we need, first and foremost, to keep our nursing homes sheltered and in place. That is obviously our par one, our most important area. So that's, again, an opportunity, which we have not done a very good job in the past, that we can do now moving forward. So what do you do with all the other folks? If you're asymptomatic, if you're under age 65, if you don't have significant comorbid diseases, why are we penalizing in North Carolina the infinite number of individuals who do not fit in high-risk categories and push them into poverty? I think that's a discrepancy in our policy. I think that's something that we should not be doing. All the states that border our state, Georgia, North Carolina, Tennessee, they've changed those rules. And our lines and their lines are no different. So it makes me question why. We go back to why Republican governors are doing one thing, why Democratic governors are doing another thing. And, is it politics? Is that what the motive is? I don't know, but there's definitely a difference, and why that is, I just don't know. Unfortunately, the state just lost probably over $150 million because we had a convention that was going to be able to come here to Charlotte. Badly needed dollars. And it's unfortunate that there could not have been something that folks sat at the table showing how important that was to the state and worked out a compromise. Those are terribly needed dollars for North Carolina, and it's a tragedy to this state that something was not worked out. So let me end with this, guys. Unemployment leads to poverty. Poverty leads to despair and health inequities. And health inequities and despair lead to death. So why, in the face of clear data from this state and every state around us, do we persist in keeping people unemployed? What justification can there be for keeping a bingo parlor unemployed? People are sitting 6 feet apart, they have a mask on, somebody's calling themselves up here. We're picking winners and losers indiscriminately, and that's wrong. We're keeping people unemployed. What happens when they're unemployed? They lose their health insurance, and they don't get the relief. And I know the governor wants Medicaid expansion in the state. He's made that very, very clear. But I don't think keeping people unemployed and impoverished is the way to do it. We've had 3 W's instilled in our brain: washing our hands, wearing a mask, and be willing to do social spacing. So I'm going to submit to you that moving forward, we have 4 C's. Number 1, a coherent plan for testing. I just gave you one. We test in our nursing homes. We test in our high population areas. We do not only contact testing, but we do antibody testing and surveillance testing. Number 2, communication and transparency. That's been horrible. That's not been good so far when a lawsuit has to be given to the state administration to get information that the public needs to know. There needs to be consistency amongst regulation, not changing the goalposts. Why are our elective surgeries cut out when elective abortions were not? Why do we have to limit 25 people in a room wearing a mask when you have thousands of people out not socially spacing and not wearing a mask led by the governor of the state? It's inconsistent. And then collaboration, guys. We need interagency collaboration. We have healthcare institutions in this state, healthcare systems that have offered to help. They're the ones that have taken care of the patients in this state. They need to be utilized. They have the processes in place. They're the ones that can have swarm teams that go out to nursing homes, and they can do this. I come from the Biden healthcare system. There's Atrium system in the West. The Greensboro Moses Cone system. We need to use those institutions that are already in place, and our state collaborate with them to get a hold on this crisis. So I know that was a little bit long-winded. I'm happy to answer any questions that you might have. I think we've done good things. I think we've missed opportunities, but we're in a rare spot now where things are going up, where we can learn what we've used from the past and make things better for the state moving forward. And with that, I'll stop.
Going back to the conversations that have been had with Dr. Burks, she, from what I gleaned, she had said that NC trends were problematic before reopening, that this goes back to the beginning of the data. The dashboard has been changed multiple times here in the state. The way the data has been displayed has changed multiple times. So has the ability to access the data and download it and be able to keep track from a media perspective or from whatever, person at home who wants to keep track of their own county. It's been an ongoing battle to try to tackle that. So I think that's what Dr. Burks was getting to. Did she elaborate more on that? And if she did she say what kind of changes need to happen?
Well, when we on our conversations that I've had with many of those officials, and in this one particular conversation, she said there was some type of systemic flaw that had led us to have a gradual, persistent, a defined slope in the number of cases that goes back from when we started this whole thing. She said she's not here. She said she could not finger it and put an eye on it. But I will tell you this, I do believe some of the things that we just pointed out about testing. I really do think that we can use this opportunity to say, okay, well, maybe we didn't do it then, we didn't know about it then, but we do know some definite things moving forward, how we can use swarm teams, we can use resources that are already here in our state, and not educational resources, not data crunching resources, but institutions, medical systems in our state that can do this. That's how we deal with this. But she couldn't put a finger point on this, but she was very emphatic that she said this did not have to do with reopening the state.
So at some point in time, we've had some sort of glitch or a reporting issue where it's skewed our numbers in such a way that it looks like we're increasing, but we're not. I'm just trying to wrap my head around it a little bit.
No, I wouldn't say that. It is difficult when we get reporting issues, comparing apples to apples and those type of things, and it is when they've changed the variables and you understand. What she has said is that if you look at the longevity of our curve since the beginning of this pandemic, it has shown the same slope going up. It's not shown a bunch of peaks and valleys that you think would be reactive. You know, some of the peaks and valleys you're going to see, like over here, are just when somebody loads a test for 3 days and doesn't show it up to the lab. But what she said is there's something that's intrinsic in the way that this state has been dealing with the process that has intrinsically led to that persistent rise. That there's some intervention that we have not done that has led to our persistent rise when compared to other neighboring states. And as I understand, she actually called the secretary literally with that specific concern.
Well, but we don't know what that intervention is.
No, we don't. But that's why, you know, again, using things that we've not done, that other states have done, that have, you know, that opened up, and we didn't open up, and we have the same curve. So perhaps if we had used those interventions and we have been able to open up, we would just still be in the exact same spot we are today. But a lot more people employed and a lot less despair out in our communities.
Do you think if we had intervened with antibody testing and surveillance earlier on, we'd have a more robust image of especially our urban areas where these outbreaks seem to be happening, mainly because there's a lot of nursing homes and assisted living facilities in a more urban setting? Although there was an outbreak in Blake, which is kind of... Doing
antibody testing right at the beginning, I don't think was appropriate because the inoculations weren't coming in. They had, you know, yeah, there are some folks that we think, you know, everybody and their brother thinks they had it back in December. I thought I did. But I don't think at the beginning antibody testing was appropriate because we just didn't have those numbers and we needed to do the antigen testing, which is testing for the virus, at the beginning. But this, I think it probably could have been started a month ago. To start doing our surveillance testing again. We would have been finding out. Now we just found out yesterday in Greenville, there are 2 nursing homes that are now have become hotspots. So if we'd have been testing those places, again, those areas that are ripe for having problems, we perhaps could have popped that up and really stopped it beforehand. It's definitely an opportunity. Again, I'm not casting aspersions. I'm saying we didn't do this. Let's learn from it. And let's work together with other entities. And let's do better because let's blunt our curve from keep going up.
There was also the rollout this week of the school reopening where they had talked about students not having to wear masks, but that staff would probably be required to. There's been a lot of debate back and forth about the whole mask thing. As a medical doctor, I wanted to get your opinion. A lot of parents are asking me every day, is my kid gonna have to wear a mask? I don't want my kid to have to wear a mask, or I do want my kid to wear a mask.
I'm going to tell you what my belief on masks is, and I'll be very clear about this. And I'm looking at the science and the data. I think the science is very clear that individuals who wear masks decrease the transmission to other individuals. Now, WHO came out earlier in the week that said that transmission from an asymptomatic individual is very, very low. Dr. Birx and I agree completely that that's a bunch of hogwash, that we do think that asymptomatic spread does occur. And this is one of those times when you have a parent that, makes you wear, the heavy coat to school, didn't want to, and then you realize it dropped down to 20 degrees afterwards. I know people don't want to wear masks. I've worn masks for 30 years and I'm used to them, but most folks are not. I will tell you, I don't like wearing them, and everybody else doesn't like wearing them, but if you're going to be in a congregate setting with a large number of individuals for a sustained period of time, not for 2 seconds, I believe people should wear masks. I don't believe there should be state law that mandates them, but I believe we have data that's shown that it does help with the decrease of spread. Now, again, the policy is about what schools all over the place, and I can't really figure out exactly what that policy is going to be.
Anybody in the back there have a question?
Am I that good a teacher?
I have a question about when you talked about, how we failed with nursing homes and facilities. Can you, talk more about what you would have wanted to be different or what you want to improve upon now with regards to?
So I think that we didn't clamp them down soon enough. That's one thing Florida did. They clamped them down immediately. If you look at the death rates and compare us to Florida, the death rates for nursing home patients, comparing Florida and North Carolina, are pretty much the same. But you would expect that because you wouldn't expect that, Mrs. Johnson and Florida is any different than Mrs. Johnson here in North Carolina as far as their general comorbidities and everything. So I believe it was the case fatality rate was around 11.5 in Florida, and maybe 12.6 or something in North Carolina. I wouldn't take that as a difference statistically. But the cases themselves per 100,000 were about 50% more in North Carolina than they were there. And again, this goes back to using local resources. I know county health departments, I've spoken with a lot of those folks. They don't have the necessary means in this pandemic to do this. And I will speak to just distant or different system presidents. They have resources. They have swarm teams that can go with nurses and all these other things. They have the resources to go in and do testing. And if there is, knock everybody out, do contact testing, do antibody testing, doing all these other things. You know, I'm not going to say fail. Again, I'm not here to point out blame. I'm just going to say this was an opportunity that we had that we need to learn from moving forward. You know, we didn't do a great job with it. But, you know, again, everybody's learning as we're doing this. I think Florida did a great job with them. So let's learn from that, what they did there, and let's apply that here. I wish it had been done a little bit earlier. Yeah, I mean, we can all play the wish scope with this. But let's learn from that, move forward, and see as our numbers rise, let's knock them back down again.
One more thing, have you had a lot of time to wander around the DHHS dashboard at all? There's multiple ones. There's one for congregate, there's one for hospitalization.
I do it when I can. I look at several other, you know, I do. I try to synthesize data from all across, you know, Washington, Johns Hopkins, and everything to get a good idea. But I have been across our dashboard.
The hospitalization one, it took us a few weeks to get an answer from DHHS, but they have a listing on there that shows the ICU beds and the hospital beds and the percentage used of those hospital beds. And finally they added a little disclaimer after a few weeks of us asking that percentage actually is all patients in all of those beds and not specifically COVID-19. But they also don't have one metric on there that we've been asking for a while, and that's the recovery rate. Do you think it's important to have the recovery rates included?
I do. I do, because again, you know, we don't want to be fear-mongering. We want to be fact deliverers of fact. Now, I will tell you, there is some inherent difficulties with getting some of that data. The lab companies are required to report positives. They're not required to report negatives. And that doesn't mean somebody's recovered. That means somebody doesn't have it. But it would be good to know, and I believe last time I checked, we had 56, and this is just rough estimates, 56,000 cases, and I believe there were 23.9 thousand recovered, which the math on that doesn't add up, because that would mean that we would have still, 30,000 people still at home sick and everything, or still in the hospital and everything. So the math didn't add up on that one.
Okay.
It would be nice to know that. But I'd much rather have us do the other things, the collaboration, all the other stuff, as we're moving forward, to really actually change the bar in the future.
And just one more thing to kind of like clarify with the, I guess like year and what you spoke with Dr. Burks about, with the increase not being related to reopening. Is that because it's been a steady incline versus like it spiking at reopening?
Right. So the best thing I can, maybe we can, everybody's a cook in here. I'm not really a cook. If you have a bowl of something and you're pouring in chocolate syrup at a slow rate the whole time, it's going to get more and more chocolatey every time, and your chocolate quotient is going to go up at the same rate. Well, if you're doing this and then all of a sudden you dump a bunch in there, it's going to get chocolate really quick. You're going to see a spike. We don't have any of that. We don't have a massive spike. We have a slow, persistent. The slope has been very, very similar and very consistent through the entire thing. So that tells us that there's a consistent policy, premise, or something that's been going on in the state since day one that either we're not attending to or is specific to North Carolina, which I just can't believe. We're not any different than our populations are no different in South Carolina and Georgia. And so that's just that's the best way I could give you an analogy on what that means.
Could it be, could that part of that flaw be maybe the fact that the tests that they're doing are for people who have either been in contact or could be presumed positive, they're in a pool that would have a higher rate of potential positives. Sort of like, you know, you go fishing in a pond and, you know, you're looking for trout, but you're fishing in a pond that's only stocked with trout, so that's what you're gonna catch.
Yeah, and that's, again, when you test more, you find more.
Right.
That's the one specific thing. You know, at first, we brought back, it's like with masks. We told only people who were symptomatic to wear masks. We've learned from that, okay? We've learned a lot of data from that. And the same with testing. We told people only if you're symptomatic, which you should get tested. And that's right at the beginning, and that was correct. Now that we've progressed and we've had 3 months of data, we know that we should be doing a lot more and more widespread in different types of testing.